Good morning, everybody. Welcome to our first UK Healthcare Tug of the year. I know it's almost halfway through the year, so it's a bit late to be getting going, but we've had a new format change as you've maybe worked out. So last year, our first year being the UK Healthcare Tug since we restarted it, we were doing quarterly 3-hour-long hybrid meetings, so in person and virtual, but we were finding that they weren't particularly working out well for us. It was so we've gone to monthly virtual shorter meetings that hopefully you'll all enjoy just as much as you did the longer form ones. But you'll get content now every month, and we've got our next 4 booked in. So just head to our Bevy page where you can sign up for the future ones. But enough about the future. We're here and now. Hello, welcome to the UK Healthcare Tug. I am, just getting my presentation going. There we go. Hi, I'm Charlotte. You may recognise me from the other tugs from last year that I was hosting. I work for NHS Arden and Gem CSU. I've worked in and around the NHS since 2008. And also last year I was honoured to have been made a Tableau ambassador, which was directly because of the work I'm doing here with the tug community of promoting my own tug, but also promoting and supporting other tugs around the world and in the UK. So that was really good. My other co-lead is Steve Adams. He can't be here today. And later on in this meeting, we will be revealing a new co-host to you all that we're very excited to be welcoming. Just a little bit of admin here. So we've got, as I said, I love promoting tugs. Tugs are fantastic. So I just wanted to promote some upcoming tugs that I think you'll be interested in. So on Monday, just bring up my notes page so I can tell you all about it. So on Monday, there is the AI Tug at 5 p.m, which features 3 speakers. So first up, there will be Pablo Gomez, who will explain how colour theory can enhance your vizzes for better readability, impact and storytelling. And he'll also show you how to create custom templates for accessible, inclusive designs and to make the design shine. Now, I saw this presentation at DataFam Europe in November and it was brilliant. So he's been doing it at a few tugs, so if you don't manage to catch him at the AI tug, I'm sure you'll be able to see it again. Then they've got the king of Tableau Viz extensions, Tristan Gillivan, showing you how to use ChatGPT with Tableau extensions to unlock new ways of talking and interacting with your data. And lastly, they've got, and I might say this name a little bit wrong, Christian Cerveda des Moineaux and IMViz champion Will Sutton talking about how Tableau LangChain bridges the gap between trusted data and modern AI frameworks. In their session, they'll unveil 3 AI capabilities that enhance what you build with the Tableau platform. So yeah, AI is obviously a very exciting new world that we're all learning about. And this tug started, I would say, autumn last year. So it's a relatively new tug. So please support that if you can. Then on Wednesday, you can join the Data Plus Maps tug at 10 a.m. To see Lorna Brown from the Data School demonstrating a Workout Wednesday solution, which creates an exploratory solution to finding the closest tube stations and other attractions to specific London experiences. And this will include using map layers and spatial calculations to create an elegant map with all relevant information in. Now, you may be thinking, we're the UK Healthcare Tug, what has, the London Tube got to do with us? But you could actually, quite easily use this solution in our healthcare, replace tube stations with hospitals. And you've got quite a nice little map that could help the public there. Also, a shout out to the other UK Tableau user groups. There's the London Tableau user group. I've noticed a lot of you in the chat saying you're from London. So do head over to their page to see where their next event's coming up. Notice that Hayden, you were in the East Midlands. There is the top of the Nottingham user group. There's also the Scotland user group. I don't think any of you mentioned you were from Scotland. The North East Tableau user group. And for those in the Northwest, which I noticed, Paul and Miriam, you both said you were from Lancashire and Manchester. There's the Northwest Tableau user group for you. So hopefully a regional user group close to where you live that you can attend. There is, of course, tons of user groups that you can join, not just the ones that I've mentioned here. If you're new to Tableau, there's the Tableau newbies user group. There's the analytics user group that are all very useful, and virtual global user groups that are really good to attend. So enough about me plugging Tableau user groups. You're all here to really hear from Matt. So I would like to introduce to you Matthew Conroy of NHS Greater Manchester. He's the Analytical Service Lead for Primary Care, and he's here today to talk to you about his CVD need tool, I think that's right, that helps tackle CVD in his area. And he's told me he could speak for hours on the topic, but I've given him 45 minutes max. So I will hand the reins over to him.
Fantastic, thanks Charlotte. So I will get my screen share going, just making sure I pick out the right window. This is where you realise how many windows you have open at one go. There we go. Hopefully you can all see some slides.
Yes, we can see them, thank you.
Perfect, thank you. So thanks to Charlotte for inviting me along today to talk about the work we've been doing about cardiovascular disease in Greater Manchester. So just by way of some background, I'm the Analytical Service Lead for Primary Care. And when we say primary care, we actually mean the four primary care disciplines. So that's general practice that most people refer as primary care, but also community pharmacy, dentistry and optometry. I've led on the use of GP data across Greater Manchester for 9 years. It'll be 10 years this summer, which has just flown by. And I'm also alumni of the NHS Graduate Management Training Scheme back in 2014. So I thought it was useful at the start just to give some context about Greater Manchester. So NHS Greater Manchester, we're the ICB, and we cover the 10 local authority areas, and we serve a population of over 3.2 million patients. I think we're nearly at 3.3 now. GM is fairly atypical. It's the region is one of the most deprived according to the indices of multiple deprivation. So for those of you who are familiar with IMD, 50% of GM is in the top 2 IMD deciles, which is significantly atypical than the rest of the country. We face long-standing health challenges in a population that's growing faster than the UK average, and with an increasingly complex burden of ageing and multiple long-term conditions. Inequalities both in terms of health outcomes that show significant unwarranted variation at both the place, so that's what we call our CCG footprints, and neighbourhood levels within and across GM. Not painting a particularly rosy picture of Greater Manchester, but a particular challenge that we have is around cardiovascular diseases. So CVD is an overarching term for a group of long-term conditions that includes atrial fibrillation, chronic kidney disease, coronary heart disease, diabetes, hypertension or sustained high blood pressure, peripheral arterial diseases, strokes and TIAs. So over 500,000 in Greater Manchester have a diagnosed cardiovascular disease. So by diagnosed, where there's a record of it on your GP record, and over 40% of those patients have multiple cardiovascular diseases. GM has some of the highest rates of heart attacks and strokes, both in the northwest region in England, and GM has significantly high rates of mortality for cardiovascular disease. To try and tackle this, GM has a system-led concerted effort to detecting, diagnosing and managing CVDs, and data is a critical tool to help understand the impact of them and how we can reduce their burden. So given the context of GM, I thought it was worthwhile just quickly giving you an overview of our data and intelligence stack that we call the Analytics and Data Science Platform. So we have data flows that come from NHS England, we have our Greater Manchester Care record that I'll touch on in a minute, and we also have our local data flows. We use Snowflake as our cloud data warehouse that we also call the secure data environment. And then within that, we have our health and care intelligence hub. So we use Tableau as our data visualization product. And then we also use the Curator platform that we buy off Interworks that we use as our intelligence hub that acts as a portal for users to access our Tableau dashboards, but is a one-stop top for intelligence across the whole of Greater Manchester. We then also have our trusted research environment, which allows different users to access the data for different purposes. What underpins our CV Need tool is access to GP data through the Greater Manchester Care Record. So the GM Care Record is our shared care record platform of choice that pulls together data from across GM. So the analogy I always like to use is that if I was hit by a bus, knocked unconscious, and I rocked up at Manchester Foundation Trust A&E department, that the GM Care Record would allow a clinician to look at my GP record and see what conditions I've got, if I'm allergic to different medications, and to try and facilitate that system-wide approach to care. We piggyback off that flow, which allows us to access identifiable patient-level GP data, which enables us to then build a really rich picture of all of the demographics and prevalence of long-term conditions across Greater Manchester. So with that data and the context of CVD, the aim of the CV Need tool was to understand the impact and burden of cardiovascular diseases in GM using the routinely coded GP data, to undertake a population health management approach, quantifying inequalities in CVD management by different demographics and protected characteristics, quantifying the impact of multimorbidity, so multiple long-term conditions, and identify, target and prioritise those most at risk by using a classic PDSA cycle. What makes CV Need slightly different is we've undertaken a process to prioritise patients. So high-risk stratification and prioritisation is a key strategy for PHM. So we developed a person-centred prioritisation that we dubbed CV Need, so cardiovascular unmet need. So to do this, we identified some fantastic work that looked at single condition prioritisation. So prioritisation for patients with diabetes or with high blood pressure or with chronic kidney disease, but each of those only focused on a condition. And what we wanted to do was look at something that was more patient focused. So looking at a patient, what conditions they have, how well they're managed, to identify where there's opportunities for improved management. Which just so this is prioritisation, it's not risk prediction. So what that looks like, this is a flow diagram that we developed for our prioritisation for diabetes specifically. So if I zoom in, we start by saying, are you actually on the GP register for diabetes? If you're not, then you don't have a CV Need score. We then say, is your latest blood pressure, do your blood glucose reading, HbA1c, ever more than 86? If it is, then we say you're in category 1 and we give you a score of 24. If it isn't, we say, is your last blood glucose reading more than 75? And are you mild, not frail? If it is, then you get a C and you go into category 2A. We then adjust for frailty and go to 2B. So essentially, this way of giving a score based on the control of diabetes, but then also if you were a hypertensive patient and you had the most uncontrolled blood pressure, that would give you a score of 20. So your combined patient score is 44. So we can give that prioritization across a patient and all the conditions that they have. But rather than be talking about the theory, let's bring up the actual dashboard so you can see what that looks like. All of the dashboards that we have across NHS Greater Manchester have a standardised format with a cover sheet that just gives some information about the dashboard. We found that this is really useful for our users in terms of standardising. So there's numerous different tabs that we have that enable the users to really drill into and understand different conditions. So this is looking at the prevalence of diabetes. So we can see a headline figure that the prevalence of diabetes across Greater has gone from 7.7% up to 8.1% with some little bumps around that. So what we find is that because GM has quite a lot of students with its population, that we see around September and October every year, our list size is dramatically increasing because of students, which then we see some kind of bumps around prevalence around when patients register, and that younger people are less likely to have diabetes. So that's what we see, these little drops. But in general, we see the prevalence increasing. But then on the right hand side, we've utilised parameters in Tableau to then demonstrate how the user can start to break down. So this is currently set by age bands, but we could choose to break that down by ethnic category, for example, and then the users can see that diabetes prevalence is highest in the Asian or Asian British population, then lower in the, well, we don't know patients' ethnicity or from mixed or multiple ethnic groups. What we've then done for visibility is hidden the filters behind this pop-out. So if you were just wanted to look at the diabetes prevalence in Manchester, you can then filter down to Manchester and then all the other parts of the dashboard take account of that. So you can see actually that in Manchester, the prevalence is slightly higher for the Black African, Caribbean or Black British groups. If you wanted a very quick and simple guide about what this means, you can then click on search description, but as ever done a live demo, that has not worked. We can then go through and look at the CV need score specifically. So if I just reset this to look at the whole of GM, he's hoping now that the show descriptions did work when I tested this, but that gives the user a detailed description of what this is showing them. So we can see actually for diabetes as of the end of April, that 8.6% of the diabetic population are in that HbA1c category 186. So we would say that they're the highest priority patients. So we can see in total that 15.1% of our diabetics are in that category there. We then look and see what that means in hypertension. And again, this is all done with parameters to filter to specific groups. So we can then see that there are 6.1% of our patients with hypertension, high blood pressure, that are in that very high categorization. We could then look at our primary prevention for lipids management and see actually there are 5.7%, but these weightings span across patients. So then we also have our distribution page where you can then see the totality of actually if we band patients into kind of categories of no need, low need, medium need, high need, or very high need, how they vary based on their cumulative score. So we've got a total distribution here, but we can see actually there's a very small number of patients with a very high score. Because we have all of the data sitting in the background at an individual patient level, again, we can track and see how this changes in time. So what we can see is that for example, diabetic patients in that very high or high prioritization, that we're really starting to see that drop, which is demonstrated that we're doing with our GP practices and how we surface this information to them to make them aware of the patients who are at high risk. And what we can see from some of the data and dashboards is that actually when we track this forwards and backwards in time, that we're starting to reduce the gap in our BAME groups at a faster rate than we are from our white British groups. We then utilize some of the maps within Tableau to then demonstrate how this varies geographically. So these maps are based on the individual, on the patient's postcode. We aggregate up to the lower super output area to demonstrate where there are hotspots across Greater Manchester. So what we've done here is we've said that we're looking at the percentage of patients with a CV need score of 28. So that's a high or very high prioritization. So what we can see is that there's certain hotspots over here in Tameside, certain parts of Oldham, certain parts of Bolton, Watchdale, and Manchester, where there's a greater proportion of patients who live in those areas who have a greater need of prioritisation because of their cardiovascular disease care. And this is actively being used by practices and neighbourhood teams to target patients based on where they live. So not only looking at the services they access, but also the geographical areas where they live, understanding what other social determinants there might be for their health, engaging with them in local community centres, and really using this tool to drill down based on where patients live rather than the services that they may access. Because in a lot of cases, we know that there's certain groups who are quite hesitant to go and see their GP, but if they were to see a community field worker within a community centre, that might offer a slightly different approach for discussing the benefits of seeing their GP and how they can monitor and improve their care. What we've also done, and this has been in development for a while but rolled this out, is we can link the GP data categorising patients based on their disease care to wider system usage. So across these coloured lines, band patients based on no need, low need, medium, high, and very high need based on their CV need score. And then the height of the lines indicates their average non-elective admissions for CVD per 1,000 head of population. And what this demonstrates to us actually is that our prioritisation shows that there's a clear link between poor cardiovascular disease management in general practice and wider system utilisation for cardiovascular disease. This is exactly what you'd expect on paper, in that essentially if you have a really uncontrolled diabetes, then you're more likely to go to A&E or have an emergency admission for your diabetic care. But it demonstrates at a very high level that the methodology that we've developed around categorising patients in general practice actually demonstrates wider system utilisation, both for non-elective admissions, but then also for utilisation of things like 111 calls. The differential isn't clear here because we can't break down our 111 data by for cardiovascular disease specific, but in general it demonstrates that actually that if you have poorly controlled cardiovascular diseases, then you're more likely to have other conditions that are poorly controlled as well. Within the dashboard, we've also tried to develop something that's quite user configurable to actually help them identify specific things. So we've got where you can pick a condition, such as set to diabetes. We could then say we want to look at the trend in patients whose last HbA1c reading is less than or equal to 75. So patients in scope is patients who've actually had the reading within that in a 12-month period. That's eligibility, and then patients in scope is actually who've had that reading. It's quite a complex viz, and we're still trying to figure out the best way of designing something that gives all the users the configurability that they want, whilst making it as easy for them to articulate and drill into exactly what they need. I think when we were kind of testing and developing this, what we found is that the data is really useful at a population level to help actually understand who are the patient, or where the patients are on a high level, who are the groups that need to target. But you can only make real change when you have access to the patient level data and actually look at the actions on a per patient level. So the challenge that we had is how can we support clinicians to manage patients on an individual basis? This is quite busy, but what we've done within the data is we started to overlay our medication pathways to identify where there's opportunities at an individual level. So if I just zoom into the right hand side here, this is our Greater Manchester adults hypertension medication pathway. So what this says is that essentially if you have high blood pressure and your blood pressure readings are outside of these targets, then this flowchart helps you to navigate which medications are best for those patients. So if you are under 55 or you're a type 2 diabetic, you should be started on an ACE inhibitor class of drugs, ideally linezolid at 10 milligrams. If you are over 55 or from a Black African Caribbean group, you should be started on a calcium channel blocker called amlodipine. If your blood pressure is really high, so more than 160 over 110, actually the recommendation is that you should be started on both straight away. If your blood pressure still isn't controlled, then we should up your linezolid to 20 milligrams. And if that doesn't work, increase your amlodipine to 10 milligrams, and so on and so on. So what we've done with the data is overlaid these pathways on an individual patient level basis to look at where there might be medication actions that we can suggest. So if I just jump back to the dashboard for a second so you can see what that looks like here. So hypertension is quite a straightforward one to do. So what we've done is on the left hand side here is we've got the different prioritization categories, so 1, 2, 3 all the way down, and then across the top here we've summarized the medication actions. And when we were building this, we were under the impression that quite naively that patients with the most uncontrolled blood pressure, for example, had the metaphorical kitchen sink thrown at them in terms of medications, and that they were in that fortunate position where there was not much more that we could do to support their management. What we actually found is that for those patients in this top category, nearly 50% of them have a medication action from that pathway. So of those nearly 28% of them, the suggestion is to start a new medication. So it might be that they're at the top of that diagram, they're on an ACE inhibitor, but they haven't been offered a calcium channel blocker. Whereas another 17% of them, actually, the recommendation is that they are on, say, linezolid 10 milligrams, and they should be increased on their dose to linezolid 20 milligrams. What we did as part of this is to say, actually, if somebody's blood pressure reading is more than 12 months old, we shouldn't be suggesting any medication actions. The first thing that we would recommend is that the practice comes back, brings the patient in, they do a blood pressure assessment, and then look at what actions need to be taken. So nearly 19% of patients with the most uncontrolled blood pressure are in that category. What was really surprising is that nearly, or just over 29% of patients have been given a new medication, but their blood pressure hadn't been checked since they were given that medication. So actually, the blood pressure, the new medication might have done exactly what we've expected, is to control their blood pressure, and they might now be dropping down into the categories. We just don't know about it because we haven't followed up their blood pressure. And quite surprisingly, in total, 10% of all patients in this group had the metaphorical kitchen sink thrown at them. So we've built this for as many of the medications as we can. So that's been built for hypertension, it's been built for atrial fibrillation, it's been built for chronic kidney disease. So we can then really start to drill into what are the actions that we think we need to take. And then this is accumulated in a view that we're calling patient level actions, where it summarizes for all patients how many cardiovascular diseases they've got, what their total CV needs score is, and then what actions they have, both in terms of what readings they need. So is it that they've had a blood pressure reading that's more than 12 months out of date, but then also what medication actions they think. So if you hover over, you can then see that this is a 76-year-old female, the CV needs score is 44. She's got 3 cardiovascular diseases. She's got atrial fibrillation, type 2 diabetes, and coronary heart disease. So we can see the last readings. And for this patient, we're suggesting that she needs an up-to-date cholesterol and blood pressure reading. But because of her coronary heart disease, she should be started on a statin, atorvastatin 80 milligrams. And because of her atrial fibrillation, she should also be started on a DOAC. So right now, this information exists at a patient level. We have what we call a pseudo ID, which is just a fake identifier for an NHS number. As an organisation, we're just going through approval to do what we call re-ID. So all the technical bits have been worked out behind the scenes. So our data infrastructure and technical management group have developed a Tableau extension where eventually there'll be another button here which you click, which will be like re-ID. In the background, that calls a secure API that converts the pseudo ID back into a name and an NHS number. So then the clinician can use this dashboard, go on and find specific patients that they want to target and look at their actions. We've also literally this week proposed a solution where, as well as the dashboard surfacing patients and you can find who they are, what we call the reverse lookup, where a clinician could go on here, they could type in an NHS number and then they could find the specific actions for that patient. So then it almost doubles the use case. So one way of looking at this, that if a GP wanted to run a specific clinic and call in certain patients, they can use this view to find who are the patients with the most actions and the greatest need. They could also do the reverse, where if they were sat in front of a patient who got uncontrolled hypertension, they can quickly log onto the dashboard, key in their NHS number, and then bring back all of the information specific to that patient in that moment. I think what we found is that whilst it was quite surprising that a lot of the medication actions weren't being followed up, it's just because in that moment when a GP is sat in front of a patient, the last thing you want to be doing is tracing away and finding a specific action at a point in time. And if we can do a lot of the heavy lifting by suggesting the actions through the dashboard, then that can only improve the consultation. What I should say is we're not professing that these actions are cast iron guarantee. It's a best suggestion of what is available on the GP record at that point in time. So taking this top patient, for example, we are suggesting that she should be started on atorvastatin 80 milligrams and being offered a DOAC. We're not saying that that's what the GP should do straight away without reviewing the patient, because it might be that the patient has tried atorvastatin previously and they've got a contraindication, so they can't take it or they've declined it. But if that information isn't coded on the GP record, then we can't extract that and factor that in. If somebody was to review that top patient, say, actually, I know the patient doesn't want to take atorvastatin or that they're not suitable for it, if they were to then code that on the GP record, that would then be factored in when we refresh the data again, and that the number of actions would drop down because that isn't suitable. What we've also done here is for some patients, let me find an example here. There's some medications where we think that the patient needs to be stopped with them. So this patient here has got chronic kidney disease, and a marker of chronic kidney disease is a value called the EGFR, which is a measure of how much how good your kidney function is. So this patient is on a drug called an SGLT2, but because their kidney function is only at 32, actually we're suggesting that the GP might need to review whether that SGLT2 dapagliflozin is still relevant, because in some circumstances patients with a poor kidney function shouldn't be on that and they should be considered for another medication. So we're not only trying to suggest where there are actions that can be taken in terms of giving people medication, actually, while we're also looking at deprescribing as well. And in the background of this, we've tried to cost out all of the medications to look at what impact this might have on the medications budget, and the pros of, or the con in terms of increased spend. We're trying to say, actually, well, if we negated it by deprescribing in certain areas, looking at where we can make financial savings as well. So again, this is some screenshots in case it didn't work around the medication actions, but also the what that means based on poor control. So some high-level initial testing of the actions suggested that they're correct around 80% of the time, but as we said previously, the actions are only as good as the coded data on the GP record. We've been engaging in a few different forums around the use of the CV Need tool. So we're currently working with NHS Bristol, North Somerset and South Gloucestershire ICB in terms of sharing the code base and what we've done in terms of visualization with Tableau about this. NHS Lanarkshire are also adopting this across part of the Scotland footprint, and if that's successful, then they are looking to roll that out across potentially the whole of Scotland. We're looking at how we can share some of the code and some wider of the use of this tool on the Tableau dashboard at events like this. And for my sins, the work around CV Need has demonstrated such a strong impact that we're now looking at scaling this approach across all the long-term condition areas as well. So we've drawn up a very rough version called respiratory need that looks at patients with asthma and a breathing condition called chronic obstructive pulmonary disease. And the aim is that by April 26, we'll have something that spans all different long-term condition areas. So looking at how we can scale this up across mental health, cancer, frailty. So essentially at that point, we would be deriving a single patient score by GM, for GM, that looks at not only what conditions people have, but how well they're managed, which will hopefully then give the system the tools it needs to look at where we can support patients best to manage their conditions and demonstrate that the work that general practice and the wider system is doing to improve population health. That's it for me. What I failed to say at the start, and it was a big omission for me, is that when I say we, this has been developed with a GP called Dr. Steve Mishra, who's our clinical lead for cardiovascular disease prevention at NHS Greater Manchester. He's been absolutely instrumental in terms of driving this work forward, giving some clinical feedback and providing clinical input as well. So that's it from me, and I'll take it down to see if anybody's got any questions or comments.
Right, that's, amazing. It's how long did something like that take? Pretty detailed, isn't it?
It is. So this idea first started towards the end of 2022. So at that point, this was when CCGs were just merging into ICBs, and it started off with a team messaging me one Friday afternoon. Is there any way that we can start looking at disease control and if it's improving or getting better or worse? And we found a set of searches called the UCL partner searches that did a very crude prioritization. But what we found is that their diabetic prioritization made reference to hypertension. The hypertension one made reference to diabetes. And when we started to try and look at patients, we found there was so much overlap. At that point, we had the kind of the lightning bolt moment of, well, why don't we create individual stratifications and then join them up? We probably hit that light bulb about mid 2023, and then ever since then we've just been iterating and improving it. So it's been in the back burner probably for two and a half, getting on for 3 years. Off the back of that, we built the respiratory version in about 2 months, and I think the acceleration was just because we'd learned so much about kind of building the underlying data, getting it right, putting it into the vision, that once we did it for the one clinical area, all we needed to then do is to identify the parameters that lead to, that you can use as a marker for good or bad respiratory care, build them into the data, come up with a methodology. So literally somebody in my team right now is is working on a respiratory need dashboard, which is basically taking the CV need dashboard and just swapping out the parameters and the underlying data for respiratory. So now that that's done, as I said, we're looking at scaling it up across other areas. And I think part of this is the clinical engagement about actually what does good or bad, or how should we prioritize patients. CVD is quite straightforward because there's so many clinical values. You can look at somebody's diabetic control based purely on HbA1c reading. That's very simple. Asthma and COPD is slightly more challenging because whilst there are some values, it's more based on how a patient perceives their care to be rather than actually a clinical marker. So that's where we've landed on the use of inhalers as a way of doing that. But yeah, I think it's been no small undertaking, and I think I failed to mention the fact that Snowflake has been absolutely instrumental in us being able to do this. The fact that the GP records that we have at the moment, it totals 4 billion rows, and it's only grown because when we get the GP record, we get the complete record from birth right up until the present day. It includes every time you have any reading, all of your medications. So there's a huge amount of pre-work around cleansing the data to get it into the format. But again, the move to Tableau Cloud has really accelerated how quickly we can do some of the visualizations. Previously, we had a on-premise server and the dashboard ran quite slowly just because of the sheer volume of data that was behind the scenes. We had to optimize the extract as much as possible to make it happen. But yeah, Tableau Cloud has made this significantly easier.
Cool. And obviously, one of my questions is going to be is how closely did you work with your clinicians? But you then in your thank you mentioned the doctor you'd working with. Was there anybody else on the team, or was it just you and the doctor working on this?
So it was probably me and Asim in the first instance. When we had something that was useful to be shared, we then started sharing it with our wider medical directors. So for those who aren't aware, ICBs are quite medically driven. So we have Dr. Manisha Kumar, who's our chief medical officer. She's a GP and she still works 1 day a week. Her deputy, Claire Lake, she's also a GP. So we shared it with quite a lot of GPs to kind of get some sense from their perspective. But then we've also shared it with a lot of neighbourhood teams, secondary care consultants to really get their feedback about how the visualization works. So that's where for example, hiding the filters behind that button came in, because otherwise we had the filters down the side and then you lost a lot of the space for the visualization. That's where the show descriptions came in terms of actually if somebody wanted almost a couple of sentence summary about what does this mean and how should I interpret it. That's where that came in. I think one of the questions in the chat from Sarah was actually around testing with users. That's where we did, Asim and I did a couple of road shows with a couple of users to get some initial feedback, and off their feedback, that's where we developed things like the show descriptions. But that's also where that quite complicated viz came in about somebody said, well, I've got a very specific target I want to look at. How can I do that as well? I'm not going to profess that that's the cleanest thing in the world, and I think we probably need a little bit more engagement on how we can make that better. But what's really interesting is that from looking at our Tableau usage stats, I think it's one of our top 5 most popular dashboards, and it does seem to be resonating with people. And what we also included on that cover sheet was a link to a Microsoft Forms, where if people had any specific feedback, they could complete that through a Microsoft form, and then that gets sent back to us, and we can review and make any changes based on people's feedback.
Cool. So you've answered Sarah's question. Claudia asks, can you talk a little bit more about how recommendations are made? Does it involve AI filtering? I suppose you've discussed your recommendation. They've come from the doctor, haven't they?
Yeah, so they've come from kind of our medication pathways. There's no AI involved. It's a lot of hard, complicated SQL is the honest answer. I think because if I bring up the pathway again, the pathway is quite straightforward in terms of what it looks like for hypertension. I'm using hypertension because it's the easiest one to visualize, in that it's based on, well, if you have this blood pressure reading, then you start here, but then if you have this one, you start here, but then if you have a really high one, you start with both. So what we do use in GM as well, let me bring it up, to do all this, we have a set of ETL software that it's called Matillion. So all of the actions were coded in Matillion. So in the data, there's a huge amount of fields that pre-prime some of this. So to give you a sense of how the data is built, this is the bit that builds all of the fields within the data. So each one of these squares is a block of SQL that brings out a certain attribute. So this one, for example, brings out the last SGLT2, so medication prescription that a patient has, what medication it was and what dosage it was. But then we have a whole load of other bits here. So this is all of the SQL for the meds pathway. So we start by saying, actually, what is the initial recommendations? If somebody's never had a blood pressure reading, that's where we start. We say that we shouldn't be suggesting any meds until you've had a blood pressure reading. If it's more than 12 months old, then we say, well, we're not going to do it. You need to have a new BP reading because the old one's too old. Then actually, if it's treated to target, then we say, well, you don't need anything. We've deliberately glossed over heart failure for now because that's a really complex set of conditions to parameterize. And after that point, we start by very crudely saying, if your blood pressure is really uncontrolled, then you should be in the pathway kind of this route A and C. If you're here, then it's A, then here, then it's C. And then we literally have to just kind of, on an individual patient level, scan the medications that you're on, taking account of any other doses, contraindications, to build up an action across each of the different medication groups, and then summarize that up into a final one. We're not limited, but I think we, as an NHS organisation with the access to data that we do, we have to be quite careful about how we implement AI. And I'm not going to say it was easier, but it was more straightforward for us to actually just do the hard graft and code these through ourselves, which is why when we're looking at how we can share this wider, I'd much rather just share our code on GitHub and then all the heavy lifting's been done than try and let everybody else go through the same process that we did. Because I think, if I'm being honest, the medication actions took about the thick end of a year to get right. So we got special dispensation to look for me to send a spreadsheet with the SEAMS data. He reviewed it in his practice and he said, right, it works for these patients, but here I think it's a little bit iffy. And we just kind of looped and iterated to a point where we were comfortable that, say, about 80-90% of the time, it gave people what they needed.
Super. Tom has a question of how are the descriptions meant to work? Are they pre-written text or some voodoo AI magic, which I think we've covered in you?
Yeah, it's pre-written text, but there's kind of if a patient needs to be started on Ramipril 10 milligrams, we would say, well, the action is start medication, and then we just join that to whatever the suggested medication is. So all of the stuff is hard coded in the back end of SQL, and that's partly because when we want to track in time, hopefully when this dashboard is used in earnest with full re-ID, what we would expect is that practices start to action the medication actions, and we can see there's a trend in total medication actions outstanding decreasing, which is why we went through the process of kind of hard coding it into the data, and then we can see how that changes in time.
Super. Rowan asks, is it on extract to TC rather than live to Snowflake? What's the data refresh rate? And do you know the comparative numbers for load times pre and post TCM, or a rough idea?
So it's an extract on TC, just because there's 3.3 million people in GM, so we have a row for every patient for every snapshot. So when you looked at the snapshot dates, there was about 3 years of data, so that's quick mental maths, 40 million rows, and it's only ever going to grow. So it is an extract. At the moment, we're refreshing this monthly because it's not being used in earnest for direct care. I think the intention is that when we can do the re-ID bits and people start to use it to find individual patients, we'll try and refresh it as quickly as we can based on the data that we have. So when I flashed up that data flow from the GP practice up to the care record and into our data warehouse, we refresh that every day, but the volume of data means that realistically we probably get refreshed, like a complete cut of refreshed GP data about 3 times a week, probably on about a Monday and a Wednesday and a Friday. So at that point, we will look to refresh it as quickly as we have the latest data. Pre and post cloud, the refresh probably took about 2.5 hours pre Tableau cloud, probably takes about an hour post Tableau cloud, so it's quite a significant boost in terms of speed.
Thank you. Sarah, who works for UCL, She says, it's amazing work, and she really enjoyed seeing how the work is directly impacting patient care. And then I think that's, this is the first story we've told of the year, and it's so impactful and really exciting to see. So I echo what Sarah's saying there. It's brilliant. Jason says, can you go into how the data is anonymized?
Yes, so let me go back to the data flow because it's probably easy to talk it through on there. So when the data goes up from GP practices into the back end of the Greater Manchester Care Record in the yellow box, there's a secure extract API that EMIS use, so the data comes into the clear with NHS number. So when we pull it down into our analytics and data science platform, if you imagine there's like a dotted line about here, so the data comes in with NHS number into like a staging environment. There's a routine that's made available that then pseudonymizes the data into our kind of standardized key that spans all of our NHS data sets. And at that point, it's made available to me. Nobody can access the NHS number in that kind of staging environment. We use some fancy Snowflake technology about staging environments to make sure that it comes in with the clear, but then it's only made available to us outside of that. When we do re-ID, we've got a secure API. I think it's actually with Arden and Jem who created that API for us to then do the re-ID backwards, but nobody in our organisation can see NHS number, so there's a secure process that when it kind of comes down from the back end of the Great Manchester Care Record or GraphNet into our box here, that it comes with an NHS number, but it's pseudonymized straight away before I can see any of that.
Great. Got a few more questions. So Hayden asks, did you find that having the algorithm for suggestions already defined elsewhere made it easier for clinicians to trust the output? He says, we often spend time at release of a project explaining to people why they should believe the outputs instead of immediately focusing on what the info is actually telling them.
I suppose the short answer is yes, because there is already a predefined GM pathway for a lot of this stuff. We're just, the heavy lifting has kind of been done in terms of the discussion about why this is the right best practice. It's already been signed off and gone through the relevant GM governance. At that point, all we're doing is we're saying, look, here is the pathway. We're just overlaying that pathway on top of your GP data already to make it a simpler process for you. I'm not going to deny that we still have a little bit of discussions around people not trusting what we're doing with the data, which kind of goes back a little bit to Jason's question about GDPR implications. So at the moment, because this dashboard is only used for analysis, we have to exclude patients with certain opt-outs, which means that when we first roll this out to practices, we have, well, in my practice system, I can see 100 patients, but your dashboard's only telling me 95. Where's the 5 gone? Well, the 5 is because of opt-outs, because this is, at the moment, because it's not a tool for direct care, patients with a type 1 or a national data can't use in this version of the dashboard, but as soon as we have the re-ID, we can include them. So there is still, unfortunately, that little bit of difference in terms of the numbers, but that's purely because of certain patients who've enacted certain opt-outs.
Super, thank you. Anne asks, what challenges do you anticipate in scaling up this methodology to other specialties? And then there's another question of what skill set avenues would you advise someone wanting to follow up on these types of opportunities?
I think the scale up is going to be getting that clinical buy-in. Asim was so unbelievably enthusiastic, and if I'm being honest, he probably drove this forward and gave me more nudges than was necessary to get it done. I think this was done as a bit of a pet project in the background, like when you have a spare Friday afternoons, when Google talk about these like 80-20 projects, it was very much in the 20% bracket, but as it kind of grew and steamrolled, that's where now there's been a real organisational buy-in to scale it up. I think, so when we did the respiratory bit, I think the challenge that we had was articulating to the clinical lead for respiratory what the methodology is trying to achieve, and then to try and understand from him what the clinical markers that we should be using as part of the prioritisation. At that point, we would go away, find them in the data, present them back, and then we had a couple of face-to-face meetings where we presented like a version 1 of it. We then iterated upon it and said, no, actually, you need to change that. I think we should be including this. We settled on version 2, and I think now we're on version 3. But I think the skills for somebody wanting to do this, the challenge, not the challenge, having access to GP data is fantastic, but it's quite open. So if we compare it to other NHS data sets where, for example, SUS or MHSDS, the data is already pre-formatted, it's pre-cleansed, and that a MHSDS reference table, which includes all the information about referrals, you get a contacts table, which includes all stuff about contacts. With the GP data, you actually get a really small table with 4 billion rows, which is just patient ID, date, SNOMED code, and a value. So a lot of what we've done is actually building our own table structure like MHSDS, so where we take that GP data and we turn it into a set of tables. So when I flashed up the Matillion bit earlier with all the square boxes, that's us building a table structure, which then enables us to build all of the algorithms and suggestions off that. That's been a huge undertaking, as I've been working with GP data for nearly 10 years and I'm still learning about stuff. So when our clinical lead said, right, I think we need to be looking at short use inhalers called SABAs as a marker of poor respiratory care, then we have to identify what are the appropriate codes for that, build it into the data. And I think that's where we really want to get into space where we just start sharing some of this stuff and sharing all of our code lists. There's no point in us doing that piece of work in GM and then every other ICB who's got access to GP data going down the same path of trying to isolate different codes for different things. If there's a lot of code that we can share, then I'm more than happy to do that. I had a chat with South Yorkshire ICB only yesterday about how we can start sharing some of our code and publicising it, because then there's no point in every ICB going through the groundwork we've done. If we've done the hard work, let's share it, but then also get feedback from other ICBs about where we may have missed stuff or opportunities for improving it as well.
Super. Final question from Rowan. Are you going to use some of the automatic filtering based on where the dashboard is accessed on Curator, such as specific sub-ICB, like the GM Cancer Alliance do? And can that be done down to individual GP practice?
I think we are looking at that. I think what we're conscious of is that when we get down to the realms of re-ID, just making sure that we have the dashboards that utilise the specific use cases. So some clinicians only work in one practice, some span multiple practices, and we just need to make sure that we get the filtering right to make sure that we don't inadvertently hide the position from other practices. I think what we also found with this type of dashboard is that people love a good comparison about how they compare to other areas, and that if we do too much in terms of automatic filtering, then we lose the ability to do that comparison across other areas. But yeah, the creative platform makes it easier for people to navigate and find it, and the Cancer Alliance have done some fantastic work in what they've done about URL filtering and hiding different areas.
Okay, one final question from Tom. Any timescales for when you will be able to share your work on GitHub, and are you planning to publicize it? How will we know?
Timescales, for those who got any kind of context about ICBs, we're in the middle of a very delightful government mandated cut in our function. So I wouldn't want to pin myself to any time, probably in the next few months. Publicising it when it's done, I will shout it from the rooftop because there's a lot of people asking for it. I'll be honest, I have zero knowledge of GitHub, and I think part of my challenge is for me some learning about the best way to do this. So it might be that GitHub comes later down the line, but there's a Google Docs where we start to publish this. But yeah, if you want to know anything, I'll drop my email in the chat. Feel free to add me on LinkedIn. But believe me, when this is available, we will shout it, because we want to celebrate what we've been doing, but also let other people have the opportunity to use it as well.
Brilliant. Well, if there's nothing more from that, thank you so much for coming and for sharing that work. It really is. You can tell it's a labour of love. So thank you so much for sharing. I'm just going to go back to my slides. If I can get my mouse to go where I want it to go. Where are my slides? Okay, so I teased earlier on that we have a new co-host joining the UK Healthcare TUG. At the moment, it was, for the whole of last year, it was me and Steve Adams that were organising these events for you. At the beginning of this year, we put the call out on our social media and via our emails to say, hey, we would like others to come and join our team and host with us. and we are really pleased to announce who that is today. So, who is our new co-host? Please join me in welcoming, if it works, come on, Rowan Bradnam from Interworks. Rowan joins us. Just get my notes up. Also, he's waving to you all. Wave back, everybody. Rowan joins us from Interworks, where he co-leads the public sector engagement, helping organisations like the NHS, policing bodies and central government make better sense of their data. Starting out as a maths teacher in South Africa, Rowan has always been driven by the belief that those with the fewest opportunities deserve the best support. That value has carried through to a winding but purposeful path via an MBA at Strathclyde to his current role in consulting and analytics. He thrives on breaking down silos, solving messy problems, and helping people and teams share knowledge and resources more effectively. Rowan still gets hands-on with the data, and he's happiest when making things simpler, faster, and fairer, whether that's in Tableau or how people work together. And outside of work, Rowan lives in the Peak District with his 2 children, who keep him grounded and inspired. He's into walks, football, golf, good food with friends, and the occasional overly ambitious travel plan. He was born in Zimbabwe and grew up in South Africa, and now proudly calls the UK his home. So, Rowan, what made you want to join as the host of the UK Healthcare User Group?
Thanks, Charlotte. I definitely don't think I'm worthy of that big build up and intro, but I do appreciate all that. So, thank you. Yeah, I think especially in the NHS space, there's just so much siloism that goes on. It's just inevitable the way of such a big organization, the way things happen. So that's the most exciting part of my job for me in my day-to-day work with Interworks is just helping organizations from the outside and get to cut across all the politics and all the nonsense that's going on, and definitely feeding for a lot of my colleagues at the moment, with a lot of NHS England and ICB colleagues especially not having a great time with the current changes. But being able to come in, help support and bring things together and make it work more easily and share things and connect people up. So I think I jumped at the opportunity when we were chatting, Charlotte, about joining at the TUG and helping here and just doing what I can to try and support all that kind of cross-organizational work is really a passion of mine. So I'd say that's why I was keen to jump on board.
Awesome, thank you. And just to follow up on one of your personal tidbits that you shared there, you said that you have overly ambitious travel plans. Have you got any coming up?
I have so much travel this year, actually. So I'm really lucky. I'm taking my kids to Disneyland Paris for the first time. I figure that next year, I think that big travel will be going to my dad and his wife are both turning 70. So that'll be the big holiday in the summer, doing something together with them. But this is kind of just before my kids get too cool and too old. So it's my last year, I think. So taking them along, I've never been. So I've been doing all the research and doing lots of love home swap stuff to try and make it all happen. So that's the big one. But then even though I'm turning 40 this year, a load of I think it's getting to that age where people are getting remarried and such. So I've got 2 stag trips, which I've never actually been on an abroad stag trip. I think that's quite a European or a UK thing to go abroad to in South Africa. We don't really do that. We just stay local. So even though I've been here since 2010, I guess that phase of my life has been mostly not a lot of weddings and that kind of thing. So now I guess it's round 2 when you get to this age. But yeah, so I'm going to Portugal and to Prague. And then, as I said, I'm turning 40, and so my partner's taking me to Morocco, which I've never been to either. So I have a lot of travel happening. And what's quite exciting is I don't have to plan a lot of it. So I enjoy it all, but all the planning and organization is not quite as fun. So although I think, Matthew might know a few people in his organization that tend to get it all done on AI, which you can get ChatGPT to plan your holiday. So those who are passionate about it. Yeah.
Super, thank you. So look out for Rowan. We're going to be rotating who hosts these monthly events. So I've hosted this one. Rowan will be hosting a future one. So look out for him. Say hello to him on LinkedIn. Welcome him to our little TUG family. Thank you for being here, Rowan.
Yeah, thanks. Just a little weird admin one. If you want to reach out to me, my Interworks, I'll put them on here. My Interworks email is a good one to get to me by email, and then to chat to me in Teams is my NHS one. So I'll just chuck them in the chat if anyone. I don't know what's actually on my profile within the TUG or whatever, but that's a good way to get hold of me if you want to chat. And always up for a chat.
Super, thank you. So next TUG, we're pleased to welcome Claudia, who's been on the call today. She's from Bart's Health NHS Trust, and she'll be sharing health stories and data with us, and that is on the 10th of June at 1 o'clock, and I will bung the link in the chat if I can find it real quick. Or maybe Rowan, if you could just find it for me real quick and just post it in the chat. Yeah, and my final bit of admin is to do the prize giveaway, because we all love prizes. I'll be giving away 3 bundles of swag to 3 lucky winners. So let's roll the wheel. Sarah Fretwell, congratulations. If you want to just private message me, you can, if you look at the bottom of the screen, you'll see DMs next to the chat. If you just want to private message me your email, your address that you want your little package sending to, that'd be great. And let's go for our, take Sarah out of here because she's already won it. And go again. Is it going to? Oh, I'm going to say your name wrong. Nomad Zakia, if you could again DM me your address and we will get some goodies sent to you. So I'm just writing down your name. Let's just get you out of there. And our final prize winner is Hitten. If you could DM me the address you would like your prizes sent to, that would be perfecto. And I think I'm going to stop sharing because that is everything that we had planned for today. Thank you, Matthew, for joining us to give us, that fabulous presentation. We look forward to welcoming Claudia at our June event, and thank you for coming on board to help co-lead the UK Healthcare TUG. And with that, I will close this meeting out. Thank you so much, everyone, for coming.
Thanks all.